Okay, good morning, everyone. This is Doreen from the Enlgland QIN-QIO. Thank you for joining us for today's webinar, Making the Numbers Count, Using Your Pharmacy Data to Support Antibiotic Stewardship and Infection Control. I will be muting all the lines for the duration of the presentation. Please don't put us on hold. Speakers, Amanda, you can press #6 to unmute your individual line. Before we get started, I'm going to quickly review a few housekeeping items. This call will be recorded for training purposes. The presentation is available on the event webpage. The link has been posted in chat in case you haven't downloaded it yet. Phone lines will be on mute for the duration of the presentation. And again, please don't place this on hold. We'll take questions in chat at the end of the presentation if time allows. We encourage you to post questions using the chat feature. Please make sure to send your questions to all participants. You can also ask questions over the phone line by pressing #6 to unmute your individual line or use your phone's mute button. If you need to speak, press #6 to unmute your line. If you find that the presentation is a little cut off, just use the plus and minus icons at the top to adjust your presentation window. At this time, I'll pass this over to Sarah Duranick, who is also with the Enlgland QIN-QIO, to get us started. Sarah?
Thanks, Doreen. I'd like to introduce Brittany Roy from the Maine CDC. Brittany works as a healthcare-associated infections specialist in Maine and partners with the pharmacist Jennifer Rayo to support Maine long-term care facilities with infection prevention and antibiotic stewardship initiatives. Thank you, Brittany, for being with us today, and I'll turn it over to you.
Thank you very much. As was noted before, I work at the Maine CDC, which is the state health department here in Maine, and I focus on long-term care specifically. So today, the main focus of the webinar is on Maine Veterans Home and the great work they've achieved with their antibiotic stewardship program, and they'll provide some insight and helpful pointers to all of your facilities. But first, I'm going to take a few minutes to briefly discuss the CMS rules of participation and a few questions that I get frequently asked. And I'm also going to show a quick peek at some of the Maine state antibiotic stewardship data. So if you're a Maine facility, you've likely received email from me lately asking you to complete a survey regarding the core elements of antibiotic stewardship. And we sent out this same survey in the fall of 2016, so I'll show you kind of how our state has progressed over time. I know everyone's pretty familiar with the 3 phases of the rules of participation, and one of the biggest requirements this past fall was that all facilities had to have an antibiotic stewardship program in place as part of the infection control section, and more specifically, this program must include antibiotic use protocols and systems for monitoring antibiotic use. CMS released survey pathways for many of the new requirements, so I would recommend taking a look at these pathways if you haven't already, because it will give you a good hint at exactly what they'll be looking for when they come to your facility. And the AMS program section on these survey pathways is included on the infection prevention, control, and immunization pathway. So if you look to the requirements for 2019, something that I receive a lot of questions on is what will fulfill the infection preventionist requirement, so I'll go over some of these items.
Excuse me, this is Doreen. I forgot to mute the lines. I'm going to do that right now.
And then you'll have to press #6 to unmute yourself.
Okay.
The leader has muted your line. To unmute your line, press #6.
I think we're back. I think we're back now. So as part of phase 3, which will be happening in the fall of 2019, this shows you what the IP requirement is per the regulations. So facilities must designate 1 or more individuals as an infection preventionist in the facility who's responsible for the infection prevention and control program. And here are the different requirements that are included below. So this is a very important role. So facilities should have someone in this role. And I also want to note that it's important that these individuals receive the proper amount of time to complete all of the tasks, because there are a lot of things that need to be done, including surveillance and education and antibiotic stewardship. We get asked the question a lot on what specific training will meet the specialized training and infection prevention and control requirement. Unfortunately, there hasn't been a lot of specifics on exactly what type of training meets this requirement, but I'll kind of give you whatever insight I have on this specific training. So some of you might be familiar with the ICAR tool for long-term care facilities, and your state health departments have been going around to facilities to complete this. And this is an infection control assessment and response tool to look at infection control programs. If you look at the slides here, one of the questions asks if the person responsible for coordinating the infection prevention program has received training in infection control. And underneath that, they give some examples on what would meet this requirement. So they note successful completion of initial or recertification exams developed by the Certification Board for Infection Control and Epidemiology, which is CBIC. Another example is the participation in infection control courses organized by the state or recognized professional societies, such as APIC or SHAE, and there's others along that lines as well. So this is on the ICAR tool, which was developed by federal CDC, and also on the CMS infection control pilot tool. So this just gives an example of what may qualify, and this helps with a little bit of guidance, but I'm hopeful that more specific guidance will be released in the future. And there's several trainings out there right now. Since there's not a lot of clarification on the specifics of the training, I would just be cautious on what type of training you're selecting, and going with one done by a state or professional society is probably your best bet. For facilities in the state of Maine, the Maine Quality Forum and the University of Southern Maine developed the training in anticipation of the requirements. This training is free and it's available online. You can log in and out as you have time. And there's 5 modules, including general infection prevention, infectious diseases overview, antimicrobial stewardship, surveillance and reporting, and quality improvement. And my program has reviewed this training along with acute care and long-term care infection preventionals in the state. And we're looking to expand this as well to go over some of the new rules of participation. And at the completion of the course, participants receive a certificate signed by the Maine CDC HAI coordinator and the DHHS commissioner. And you can also receive a binder full of resources for infection control. There's also continuing education modules available for bloodborne pathogens and biological hazards. So this is one training option that's available. And there's also a few national trainings that are available as well. These trainings do have a cost associated with them. So it might be a good idea to start with the main training just to get your foot in the door with infection control, and then go on to some of these larger national trainings. According to AHCA, their training does meet the CMS requirement, but again, I haven't seen anything specifically released from CMS. So they are a professional society, so I'm sure it's a great training. There's also specific APIC long-term care trainings as well, and the SHAE, CDC, and AMDA training, and these trainings require in-person components. So at this point, I can't definitively tell you what will and will not meet the requirement, but I'm hopeful that guidance will be released as we get closer to the phase 3 requirements. But again, as I mentioned, a training from a professional society that's well recognized is probably a good choice at this point. So back to antibiotic stewardship. Why are these programs so important in long-term care? As you can see from the CDC infographic on the slide, 4.1 million Americans are admitted to or reside in a nursing home during a year, and up to 70% of these residents receive an antibiotic during a year. Approximately between 40 to 75% of antibiotics are prescribed incorrectly in this setting, and nearly 50% of antibiotics may be given for longer than necessary. So there's a lot of room for improvement in long-term care and all other healthcare settings, and that's why these programs are so important. And unnecessary antibiotic exposure can result in adverse drug events, including C. diff and further development of antibiotic resistance. And this is just a schematic about antibiotic resistance. I think most people are familiar with antimicrobial resistance. It's the ability of microorganisms to survive exposure to a medicine that would normally kill them or stop their growth. And this can happen in multiple ways. And as I mentioned before, antibiotic exposure can exacerbate antibiotic resistance. So it's important to avoid inappropriate prescribing through your antibiotic stewardship initiative. And this just highlights the Phase 2 requirement that took place in November 2017. And at the bottom, you'll see the CDC 7 core elements for antibiotic stewardship programs in nursing homes. And it's a good idea to kind of look at your program against these elements so that you'll have a well-rounded antibiotic stewardship program. And these are the specific requirements related to the infection prevention and control program. And you'll see that antibiotic stewardship is a major component of this. And as I noted previously, the CDC core elements are a helpful resource when initiating and expanding your AMS program. The core elements consist of leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. And if you look at the CDC checklist, it goes into all of these components in depth. So I'll just finish up by showing some of our Maine data. As I mentioned before, in the fall of 2016, the Maine CDC HAI-AR program sent on a survey to all nursing homes to assess where facilities were at with meeting the core elements. So this was just as the new requirements were being released. This same survey was sent out again in January 2018, and we chose this purposefully because this would be after the Phase 2 requirements have gone into effect. And it just helped us to assess our progress over time. In 2016, we had a 69% response rate, and this year it was 74%, so we did have a good amount of facilities represented in this. And as you can see, our facilities made great improvements over time. You'll see the 2016 data in the blue bars, and the 2018 is in the red. So in Maine, we have 100% leadership commitment for all the facilities that participated in the survey. And some areas we're still struggling with are tracking, reporting, and education, although we've made great movement in all of the areas over time. There's currently about 55% of facilities meeting all 7 core elements, so hopefully we can increase this number over time with continued education and support. And today the Maine Veterans Homes will be tackling tracking and reporting, so hopefully they'll be able to offer you some suggestions to any facilities struggling in this area. For facilities struggling with education, the CDC recently released an online antibiotic stewardship training that you might find helpful for your providers and clinical staff. And that's all I have. For Maine facilities, feel free to always email me with any questions. I'm the last email address, and my phone number is there. And these are the other partners in my program, Jen and Rita. And for facilities outside of the state, you can reach out to me with any questions as well, specifically related to this presentation. And your health departments are always there to help as well. So thank you for including me on the webinar, and I'll turn it over to my veterans home.
Thanks, Brittany. And now I'd like to introduce the team from Maine Veterans Home and MVH Pharmacies, who will be describing their partnership and how they've used pharmacy data to support quality improvement initiatives within their nursing homes. Donna Baker is the Manager of Clinical Systems Support at Maine Veterans Home and a member of the Antibiotic Stewardship Team. Neil Thurlow is a pharmacist and the Assistant Director of the MVH Pharmacies, and Rob Potter is the Pharmacy Business Office Manager. Thank you so much for sharing with us, and I'll turn it over to you all.
Good morning. This is Donna Baker. Thank you very much for the opportunity to be with you here on the webinar today to talk about Maine Veterans Home's Antibiotic Stewardship Program. As we look at the 7 core elements of antibiotic stewardship as recommended by the CDC, the 2 elements that my colleagues and I will be discussing more in depth today are tracking, which includes monitoring of antibiotic prescribing practices, use and resistance, as well as reporting the information, specifically in relation to the data. In a moment, our pharmacy will be talking more about the specific data that they track and the process they use to calculate and report that data. Partnering with pharmacy is a very critical aspect of our antibiotic stewardship program. It's really critical to the success of the program, and they've been really key in this process. So the pharmacy provides us drug expertise to the nursing department as well as practitioners, and we also consult with an infectious disease pharmacist. The pharmacy also monitors antibiotic prescribing and lab results and reports that information to the team in a few different avenues, which I'll talk about later. They work in collaboration with nursing, physicians, and clinicians to provide expertise, guidance, and feedback. They also provide education, resources, and tools such as a treatment algorithm and best practice guidance. And last but certainly not least is the pharmacy does provide us with data such as number of antibiotic therapies per 1,000 resident days, information specific to antibiotic use with certain diagnoses like UTIs, for example, and types of antibiotics dispensed and even by route. So our pharmacy will get into more of that in a few moments. When looking at the data, we look at working with the data from a clinical perspective. We look to identify any trends versus anomalies and look at our infection rates. You can also use the data to evaluate your infection control programs and practices. It's also important to create measurable goals and clearly defined actions and expected outcomes to be able to compare, measure, and evaluate the success of your infection control program and your antibiotic stewardship program. Communication of the data is another piece. Collection of the data is really important, of course, but it's equally important to do something with the data to improve your outcomes. So we want to be sure that we communicate the data to the entire team across the board. Our pharmacy does provide our data in a clear and easy-to-read format with graphs and trending, which is utilized and shared at our quality assurance and improvement committees. Now I'll turn this over to my colleague Neil Thurlow, pharmacist and assistant director of Maine Veterans Home Pharmacies, to talk more in depth about their role in infection.
Thank you, Donna. Nice to be with you all this morning. We spoke about how pharmacists and pharmacies can support nursing in our last webinar. At Maine Veterans Homes and MVH Pharmacies, we have developed and deployed in-service education to staff within homes and provided data on a continuing basis that has become an integral part of our organization's QIN-QIO work group within our homes and at the corporate level. Pharmacists at MVH Pharmacies help support a process to optimize antibiotic therapy for our patients. This process demonstrates several areas that meet criterion under the core elements. Additionally, I would like to discuss the challenges and opportunities that pharmacists and pharmacy departments can potentially face when helping to develop an antibiotic stewardship program. In our previous webinar, a slide was called Optimization in Real Time, where our goal is to collect, calculate, analyze, and communicate. Today I wanted to share a more in-depth look at this process and how it can help lead to enhanced communication across treatment specialties. Perhaps the most important aspect to consider in this process is your EMR. The more comprehensive reporting that your system can generate offers a sizable advantage. Our pharmacy is able to access our nursing home's EMR to utilize antibiotic starts, height and weight reports, and labs such as serum creatinine and culture and sensitivities. We utilize pharmacy support databases to aid in calculating creatinine clearance and analyzing treatment appropriateness. We collect the data on these starts, calculate creatinine clearance. We then collect labs to analyze culture and sensitivities. All of these steps are dependent upon nursing, physicians, and their extenders executing a treatment algorithm, in this case for UTIs. These individual pieces are located within our electronic database and all are necessary pieces of information for optimization. As stated, the antibiotic stewardship program requires staff pharmacists to gather information from our EMR. What we found through this process was that not all information was being obtained or was not available. The key drivers behind clinical decision-making and medication efficacy in the current example are serum creatinine and culture and sensitivities reporting. Early on, we discovered that each of these clinical support diagnostics were not always present or at least only partially available. As pharmacists, we found out that these labs are not always easy to obtain or were in transit and therefore not yet available. Discussions within our corporate QAPI and communication with senior leadership led to improvements with lab data availability. We feel that this is a result of good communication and also the result of the interdisciplinary approach that we utilize in developing our treatment algorithm and training for antibiotic stewardship. Speaking as a pharmacist working in operations, myself and staff are inherently good at developing processes and executing specific workflows. Collaborating in our antibiotic stewardship program has required a shift somewhat in what we do. Developing a program requires specific meeting times and a project management focus. This is something that organizations should consider, as it will require time when developing a program. As we all know, time in healthcare is a valuable commodity. So taking the time and a shift in thinking when you involve pharmacy staff in this process. Problem solving is a key aspect to consider. Understanding how you will access data and demonstrating knowledge of multiple systems, demonstrating knowledge of multiple systems is extremely important. There's also an important clinical role as we consider the appropriate use of antibiotics in their role in treating infection. Pharmacists can play a key role in evaluating effectiveness and appropriateness of use. We evaluated our process by first looking at the time demand. We then trained paraprofessional staff to support pharmacists in gathering daily reports that are utilized for the program. Much of what we have identified involves utilizing databases. In the process for optimization, we currently utilize up to 5 different databases or clinical tools for collecting, calculating, and analyzing UTI new therapy starts. As healthcare data becomes more crucial, pharmacies can play a critical role in developing meaningful metrics for healthcare organizations. Pharmacies are well positioned to provide the framework for data reporting in an antibiotic stewardship program. That being said, gathering data and reporting has been the greatest time consumer and requires a dedicated worker a minimum of 8 hours monthly. Time aspect should be something that all organizations carefully consider as their program develops. Suggestion, and this is why I say too in all of our presentation, is to ask yourself who is good at Excel and tech savvy within your organization. Regardless of their title or role, this is someone who should be involved in the program. Got a little off track. When we started this process, there were a million ideas and questions that we all had. Our success is the direct result of teamwork and ownership across all practice specialties at Maine Veterans Homes and MVH Pharmacies. Perhaps the most important aspect is keeping things simple. We are beginning to see the benefits of optimization as broad-spectrum antibiotics are being used less frequently. The work on this is ongoing and is truly a journey. We were able to benchmark early on in order to develop our foundation. We continue to build upon what we have done, but the process continues to be ongoing. I'm going to turn it over to my colleague, Rob Potter, who's going to be talking more about data and data generation.
Thank you, Neil. In the previous webinar, we touched on the calculation that we use to establish monthly data points, identify trends, and track progress. That calculation is displayed here. I'm going to go deeper into how this is done and how you can sort and graph the data in multiple ways that can be helpful for antibiotic stewardship and assist clinicians in making informed decisions. As you can see, the calculation we use is as follows. We take the number of days that residents are on antibiotic therapies for a given month and divide that by the total number of active resident days for that month. We then multiply that figure by 1,000. I'm going to show you this in more detail in the following slide. In this spreadsheet, I have listed out 5 facilities of varying size. One column lists the number of days that residents were on antibiotics. You can see that even though facility 3 has the highest number of therapy days, they do not have the highest rate because they are a larger facility with a higher number of active resident days. What makes this calculation so useful is that regardless of the size of the facility, they can all be accurately compared. Facility 4 has the highest rate, even though they have less antibiotic therapies, because they are a 40-bed facility with 1,072 resident days. Notice the function on the top of the spreadsheet that calculates the rate for you. If you are wondering where you can obtain your facility's total resident days, your finance department or business office should have that number and can provide it to you monthly. Your therapy days can be calculated by adding up the day supply from each antibiotic order. Your pharmacy will have this information and can export it in spreadsheet format to make it easier to sort the data. It's at this point where a lot of questions arise about whether to include prophylactic antibiotics and community-acquired infection therapies. Make sure not to get lost in the weeds. To start, include everything. Now I'm going to show you some examples of how you can graph the data and what it can look like. This sample graph displays the antibiotic therapy rates based on the calculation shown in the previous slide for 11 facilities of varying size. However, there is so much more you can do with the data. I'm going to show you that in the following sample graph. This is an example of a graph that is specific to UTIs. The process is the same as the previous graph and calculations, except that you would only be including antibiotic therapies related to UTIs. You can make a similar graph for pneumonia or any other diagnosis. You can see in this graph that Facility 7 has a high infection rate for UTIs. What this graph does not show is whether this is the norm or just an anomaly. That is why trending is very important to include when displaying your data. Here is the same graph, but showing the previous 5 months' worth of data. You can see that Facility 7 has a consistently high rate of UTI therapies. Maybe this facility could benefit from some provider education. That is a decision for clinicians, but a graph such as this can be useful in determining areas of concern, identifying trends, and tracking progress. Be careful to not have too much information on these slides, or they will look too busy and be too confusing to read. This graph here breaks down the antibiotic therapies by route of administration: PO, IM, IV, ophthalmic, and topical. Some clinicians find a graph such as this useful. This is to show you how this is one of many ways you can display this data. An aspect of antibiotic stewardship is to avoid broad-spectrum medications when a narrow-spectrum antibiotic may be a more appropriate choice. This graph helps in identifying what your most utilized antibiotics are. You can take this a step further and narrow it down by diagnosis or facility. We hope the information we shared today has been helpful for you. If you have any questions, please feel free to contact us. Our contact information is on this slide. Thank you, and now back to Doreen.
Now we'd like to open it up for questions. To unmute your line, please dial #6 and ask your question. You can also ask your question via chat. Do we have anyone on the line that wants to ask a question? While we wait for folks to join us on the line, let's check with Doreen to see if we have any questions in chat.
Sarah, I don't see anything yet.
Again, to ask a question, please press #6 on your phone, and then the line will open up for you to ask.
Okay, Sarah, we have a question from Mary Obermeyer. Is the Maine education available to Massachusetts clinicians?
Yeah, this is Brittany. So it's open to anyone. We do send the binders out to Maine facilities for extra infection control resources. So if we get a ton of people who want to do it from out of state, we might not be able to provide that to everyone, but we can definitely send the resources at least electronically. But yes, it's free for anyone to take at this point, so other states can feel free to use the resource as well.
Okay, from Evelyn Bain, when you refer to antibiotic stewardship, are you talking about all antimicrobials or one or only antibiotics?
So yeah, we include, and Rob, you can help me out on this. We include so any PO medications, anything that's going to take an IV, nystatin, no nystatin,
no antifungals,
no antifungals, just antibiotics.
Okay, we have a question from Danielle Watford. Can you discuss what the folks in the nursing homes QAPI teams do once they have the data from the pharmacy? What types of conversations do you have with your physicians, clinical and non-clinical staff?
I know one, we have, it really depends on the facility. I know there's some facilities that they request the raw data that shows the medication that was used and who it was used for, the length of therapy, and they share that with their provider month after month.
And at the corporate level, it's more about just developing the program, sort of discussing next steps. A big portion of what we want to do is involve the clinicians more. We have several different physician groups and extenders that are involved with prescribing these medications. So getting out to them and educating them more, and just kind of working with our data and developing more education for staff. So kind of a little bit more of a 40,000-foot view at the corporate level, and we have our staff development coordinators have kind of taken the lead at the home level in engaging the folks at the homes.
This is Donna Baker, and one of the things I'll also add is at the home level, when we look at the data that's provided from the pharmacy, we also look at that in relation to our infection control practices. So, for instance, if we have a particular root, say eye infections, that would prompt us then to look at our practices within a particular unit, looking at hand washing technique and basic infection control. And so we do try to take a look at that data and figure out how we can create or institute some actions in order to correct any sort of trends that we might be seeing in infection rates.
Thank you. We have another question from Patricia Culver. What is an acceptable or appropriate antibiotic use rate? It looks like that from the graph, any up to 9.0.
Well, I think right now we're mostly comparing. I don't think that there's been given a target rate. So right now it's really just analyzing the data and trying to find any trends. And some of it's more about appropriate use. For example, UTIs, you wouldn't really want to be using like Levaquin on a UTI where doxycycline or Bactrim would probably be a better choice, basically trying to use narrow spectrum medications. And we can see that has been some of the progress that we have made, is that we have seen more, because of the antibiotic stewardship program, we've seen more use of narrow spectrum antibiotics over the broad spectrum medication. So there really isn't a specific rate that's been established yet.
And just in terms of, I know I talked about optimization, that's sort of the role that we play in the pharmacy is looking at that culture and sensitivity, and then seeing, if the patient is on Levaquin, if, Bactrim or amoxicillin is still susceptible, then we can then recommend that the medication be switched to a less broad spectrum medication.
And I'll also add that, again, at the home level, at the individual quality improvement committees, they look at their data individual to their home and look at goals. So, for instance, they have a particular high UTI rate, and this is based on infection data, but if they have a high UTI rate, then that helps them to understand that perhaps education in that area needs to happen. But again, you can look at your own data and make your own goals you know, and compare that over time again, choose a goal that's realistic for you.
Yeah, and this is Brittany from the Maine CDC. Something else to think about is if you're using an SBAR or another type of tool to look at your infections, so the antibiotic use rate is important, but also are your infections meeting criteria to actually need an antibiotic, and going through to see was that an asymptomatic bacteriuria that might have been prescribed an antibiotic, so you can look at things from multiple angles.
Thank you. We have another question from Latira Perry. Do you know of any program that is available for facilities to electronically track infections that will give us percentages over the course of a year?
We mostly just use Excel, and a lot of EMRs and pharmacy softwares have the capability to export the raw data into Excel format, and then it's really just a matter of sorting and graphing that data. So yeah, it hasn't been a specific program just for it.
Thank you. Another question from Shingaya Malai. Consultant pharmacist chart reviews are usually retrospective, making it difficult to obtain all complete data. Can you clarify how you obtain your data so that it's up to date, such as do you have a dedicated pharmacy team that collects data from nursing homes on a daily basis?
Yeah, so I can speak to that. So that is, it's very difficult to have, I apologize, to kind of put into a PowerPoint and explain, but so what we do is each day we do a report within our pharmacy that alerts us to anyone that has new medication, has started a new medication for a UTI. We're focused right now on UTIs. So we generate a report, any new starts on UTIs, and then we're able to go into different parts of our EMR and pull data, like I said. We'll calculate creatinine clearance. We'll look to see the updated culture and sensitivity, and then from there, analyze the appropriateness and make recommendations based on that. So it's not really, this is not a consultant pharmacist who does this. This is actually done at our Central Fill pharmacy location. And that's basically me who does that. So, along with other staff.
Okay, thank you. We have another question from Abby. How do you feel about changing an antibiotic mid-course, say if the sensitivity came back after starting the treatment, antibiotic treatment?
Yeah, so this is something, I mentioned this in our last webinar. We work with a pharmacist as a consultant. His name is Chris Perrick. He works at Israel. He has a specific specialty within infectious disease, and that's what I talked about. I talked about benchmarking. He helps us sort of benchmark the process that I talked about, optimization in real time, where if we have someone on, say, Levaquin, and it's a UTI that meets specific criteria, we're able to what we call de-escalate to a less broad spectrum antibiotic, such as, it could be Bactrim, it could be Macrobid, something like that, which will lead to less antibiotic resistance.
Thank you. From Danielle, are you implementing strategies to empower your staff in the nursing homes to be stronger advocates for antibiotic stewardship?
Danielle, that's a great question. When we look at the antibiotic stewardship program and our CLAPI committees, we really want to include and have included some of our frontline staff in becoming part of that. So not only do they understand the concept and the goals and what we're looking to accomplish, but they are also a better resource for when folks ask questions. But again, we're still working on that piece. But I think including all of those folks, that's a easy strategy. Just bringing them in, bringing them to the table, and listening to what they have to say, and helping them to feel comfortable in providing that input. As we all know, there's certainly a lot of value in including those frontline staff who are very valuable. They have a lot of really good information that might otherwise be missed. So that's one of the strategies, is really just including them. But I think through more and more education, I think people will feel more empowered as we move along, and more education specific to the antibiotic stewardship efforts that are going on. So those are just a couple of strategies, but my advice would be definitely to just include those frontline staff as part of that, because that does help them to feel empowered, and the more education they have, the better off they'll be.
Okay. From Danielle, how do you communicate with frontline staff of your efforts so they understand the why behind the what for those that are unable to participate in your committees?
So the communication, I think, is an interesting challenge, because there are several people that communicate in different ways. And so I think for us, our communication is more than just one method. So, you know, you saw the graph that our pharmacy has provided. We took a look at those at our QIN committees on both the corporate level as well as the individual home level. And so as staff are able to sort of look at that, there's also education provided. So, you know, you don't just sort of put the graph out there without any sort of explanation or information that is pertinent to the group that you're speaking with. So again, communication could be various types. In some of our some parts of our organization, they may just have a committee to talk about that. Others, they display the information. There's lots of different ways you can do that. My advice is to just, when you're talking frontline staff, say, you know, you need to be considerate of the time that they do or do not have. And so when you're displaying your information and providing education, I think it's just really important to use different ways, different mechanisms for that communication. Again, it could be electronic, it could be a bulletin board, but again, my advice is to make it short, to the point, because too much information is just overwhelming. And so another strategy around that is making things bright, colorful, fun, but again, short and to the point, to the information that people need.
Thank you, Donna. We still have time for a couple more questions if you want to post them in chat. There are no more questions right now.
Did we have anyone join us on the line to ask a question?
Oh, I have one more question, Sarah. I'm sorry. From Danielle, how do you plan to display or explain all your efforts to your state survey team?
Another excellent question, Danielle. And so we have had survey as you know, we move along into the additional phases of the requirements of participation. I'm sure that will become much more intense. And so we probably will just go over, as we do with all of our quality improvement efforts, to really sit down with that surveyor and talk about the work that we've done through the interview process, and also providing some visual data like our graphs and that sort of information. So I think that sitting down with them and just kind of going over whatever questions they might throw our way.
Thank you. Any other questions via phone or chat?
Excellent. Thank you all for the great questions. And on behalf of the New England QIN-QIO, I'd like to thank our presenters, Brittany, Donna, Neil, Rob. We thank you for all the great information that you provided today. And if anyone has any questions that you think of after today's webinar, contact information was provided for all of the speakers on the slides. We do ask that you mark your calendars for upcoming collaborative webinars hosted by the New England QIN-QIO. Our third webinar from our educational series in partnership with the Mass Department of Public Health and Tufts Medical Center takes place on March 13th, and we'll focus on strategies for implementing your antimicrobial stewardship program. And the fourth webinar of the series on infection control prevention takes place on April 3rd. For more information or to register, go to the event page on our website. We'll link that to you in chat so that you can access that. Also, have you joined our free virtual learning system? It's called the Learning Center. The New England QIN-QIO offers education in bite-sized chunks to accommodate your busy schedules while also allowing you to gain continuing education units with many of our courses. Course topics on our Learning Center, which is available free for all of you who are participants of our collaborative, include QATI, infection prevention training, mobility, antibiotic stewardship, CDI prevention, Team Steps long-term care communications module, pain management, reducing antipsychotic drug use, medication reconciliation, and much more. So we invite you to visit the Learning Center at learning4quality.org, that's 4, the number 4, and follow your healthcare settings instructions to create a new account. If you have any questions, please send us an email to learning@healthcenteradvisors.org for assistance. Also, don't forget to follow the New England QIN-QIO on social media to get important industry alerts, news, and more. And as always, your state nursing home team is available as a free resource to you as participants of the New England Nursing Home Quality Care Collaborative. For support on your quality improvement initiative, contact information for your state lead is listed here on the screen. Thank you all for joining us for today's webinar, and please have a great day.
Thank you.